Novel 4 Flourobenzyl 4-methylpiperazine overdose. Designer drugs are synthetic analogs of controlled substances popular in the market and most commonly abused across the world. Benzylpiperazine and phenylpiperazine are some of the most popular structural formulas in the making of designer drugs. These drugs and their toxicities could be a blind spot for most healthcare providers. Therefore, this case is aiming to describe a case of piperazine derivative drug overdose and its clinical presentation. We have a 43-year-old woman with a history of substance use disorder who presented from a substance rehab facility for acute severe agitation. In her room, she was found with contraband, including a torch lighter, a glass pipe, and an item with aluminum foil with an unknown white substance, 2 cigarette-like objects, and some ivory-colored cluster powder of unknown substance were found. The police retrieved these substances and they sent it for analysis. The patient developed uncontrolled movements after receiving naltrexone and duloxetine, along with severe agitation. She was therefore sent to the emergency department for evaluation. On physical exam, she was febrile and tachycardic, awake, severely agitated with dilated pupils, responsive to light, and flailing movements of her upper and lower extremities. There was no mention of rigidity, myoclonus, or increased reflexes. Further studies with a urine drug screen was positive for cocaine and fentanyl. The patient remained agitated despite multiple adjustments in her medication with Benadryl, haloperidol, and lorazepam. She required restraints due to her aggressiveness. Due to severe agitation, she had to be admitted to the intensive care unit for treatment with phenobarbital and Precedex. On day 2, she was intubated as she had an episode of emesis and was suspected to be having an aspiration pneumonitis. While on mechanical ventilation, her agitation persisted, despite high doses of sedatives, including propofol, fentanyl, midazolam, Precedex, valproic acid, and phenobarbital. Workup for other differential diagnoses of agitation and encephalopathy remained negative, including lumbar puncture, MRI, MRV, and EEG. On day 6 of admission, the substances retrieved from her room were identified as 4-fluorobenzyl 4-methylpiperazine, a drug commonly used as ecstasy. Poison control was called and recommended patient to be off fentanyl, as she had a high risk for serotonin syndrome. Supportive therapy was recommended. Sedation was weaned to Precedex and Ativan, and the patient was successfully extubated the following day. Unfortunately, the patient left the hospital against medical advice after being evaluated by psychiatry. She had capacity. In the discussion, we talked that many piperazine derivatives exist and are used in designer drugs, with consumers frequently not knowing what they're using. These substances have dose-dependent neurotoxicity, with their action being similar to those of MDMAs and amphetamines. Symptoms including agitation, anxiety, hypertension, tachycardia, and vomiting are seen in patients with suspected overdose. Although piperazine derivatives are most widely used as recreational designer drugs, they are unfortunately not commonly tested in routine toxicology. In our case, for example, sending the retrieved drugs from the patient's room to analysis play an important role in the diagnosis and management, and it should be pursued if possible in similar cases. In conclusion, there have been various non-fatal and fatal cases reported with confirmed piperazine derivative intoxication, most of the time presenting as seizures. There is no antidote for piperazine derivative toxicity, and the treatment is mostly conservative and supportive. It is important to know the clinical presentation and effects at the receptor level, which could guide the selection of medication to control the symptoms, especially given some of these combinations can result in serotonin syndrome. Thank you so much.